Hello, welcome to Chapter 6, Bone Tissue. So today we're going to look at what our bones are made up of, what kind of tissues are found in the bones, the different structures of bones, the different cells that make our bones. So, in general, our bones, they are an organ. They are one of the many systems in our body. So our bones have bone tissue, cartilage. There's connective tissue. There's epithelium, adipose tissue, blood, and nervous tissue, all found within our bones. Osteology is the people that study bones, while that skeletal system is everything that I just listed off above that makes up our bones. So what does our skeletal system do for us? It's going to provide us support. It gives attachment for our tendons and muscles. It makes up the shape of your body. It protects. It's going to protect those internal organs. In your chest, your heart, and your lungs are completely surrounded by bone, protecting them. Your bones are going to help you move. When a skeletal muscle contracts, it causes a bone to move. We maintain our calcium and our phosphate homeostasis with our bones. We need more calcium, we pull it from our bones. We have too much calcium, we start storing it in our bones. Our red bone marrow is where our red and white blood cells are made, and platelets. We'll mention where these are found in bones, and here you'll learn more about your red blood cells, white blood cells, and platelets when you get to anatomy 2. Triglyceride storage. Those fats, they are stored in that yellow bone marrow. Again, triglycerides are a form of energy. So we store some of our energy in our bones. So our bones have different areas on them depending on their shape, depending on their length. So let's go to a picture. It'll help the words above make more sense. There we go. So we have the diaphysis. The diaphysis here is that middle portion of that long bone. It's also known as the shaft of the bone. So this whole area from here to here, that's that shaft of that bone. We have a metaphysis. We have one on the top and one on the bottom. These are for long bones. So within our metaphysis here, kind of travels along this area. It's where the bone goes from that shaft where it starts to widen out. That's where that metaphysis kind of sits. Then we have an epiphysis. Again, we have a proximal, closer to your trunk, and a distal, further away from your trunk. And that includes or makes up the ends of our bones. All of our bones are wrapped in this periosteum. Pretty sure I saw it above. Yep. that periosteum. It's connective tissue. We mentioned there was connective tissue in bone. Well, bone is made up of connective tissue, but there's other parts of connective tissue. It surrounds that bone. We have what are known as perforating or Sharpie's fibers that are holding that periosteum down to the bone. Doesn't show a very good picture of that here. We have this medullary cavity. Inside of our long bones are hollow. So we have this large opening here inside of all of the diaphysis of our long bone, because we have blood supply that goes through there. We have blood vessels. We're going to have nerves. We're going to have maybe some yellow bone marrow in there. Wrapping around the inside of that medullary cavity, this endosteum. Endosteum inside, periosteum is the most outside. So that endosteum, endo, this word is going to come back. That endo and peri, you're going to see a lot between anatomy 1 and anatomy 2. So knowing that that peri, more towards the outside, that endo is on the inside, it'll help later on because it'll keep coming back. We have osteoprogenitor cells in this endosteum. These are kind of like the stem cells of bone. So we're going to find those in there. I mentioned that medullary cavity. Again, it could have that yellow marrow, could have red marrow. There's lots of blood vessels that fill up that space, that hollow space within that long bone, that shaft. At the ends of our bones, we have this spongy bone. You can kind of see all those little holes. Or if we look over at this real bone, this is a real bone. If we look at this real bone here, you can see all these little holes. It kind of looks like a sponge. That's why it's called spongy bone. And it fills up the entire inside of that top of the bone and the bottom of the bone. This darker, or this, where that bone looks more solid through here, this is compact bone. So this whole area around this diaphysis or shaft of the bone, that is all compact bone. Just kind of putting that out there. We talked about compact bone when we talked about tissues, mentioned spongy bone. So now we're going to get into more detail about it. But first, we're going to look at bone as a tissue. Bone is a tissue, has different cells found throughout it. But our bones are made up of water, collagen, and then calcium phosphate crystals. So that calcium phosphate that I mentioned, that's most common. It'll combine with calcium hydroxide and form hydroxyapatite. Calcification, this is something that happens to all of our bones. Calcification is that hardening. And it's started by cells that are called osteoblasts. They are the main cells that are going to cause this calcification to occur? Our bones need to be hard, but they do have very slight flexibility to them, and that's because of the collagen that is found in our bones. This is helping to maintain slight flexibility so your bones can bend slightly to withstand pressures before they finally break. So here's the cells that make up our bones. I mentioned in that medullary cavity, in that endosteum, there's osteoprogenitor cells. These are specifically those bone stem cells. They come from that mesenchyme, that fetal connective tissue. These are the only cells that can go through mitosis, that cell division, are the osteoprogenitor cells. The next type, we have osteoblasts. So these osteoprogenitor cells are going to differentiate into osteoblasts. That's when they divide, that is what they are making, are these osteoblasts. These blasts, as I mentioned before, blasts build. Osteo, bone, blast, build. So they're building bone. They make those collagen fibers. They initiate that calcification, so that hardening of our bones. And they kind of build bone all around them. They completely surround themselves with that extracellular matrix. They pretty much trap themselves in. So once they've built all the bone and trapped themselves in this small area, they become those osteocytes. So this cell eventually becomes that cell. Osteocytes maintain the bone. They monitor any and all bone that's around them. They get nutrients and they get rid of wastes. Because these cells are maintaining, they're monitoring, they have to be able to maintain their cellular function so they can monitor that bone around them. And all cells create waste products, so they have to be able to get rid of them. The last type of cell we find in bone. We said blasts build. We have osteoclasts. Osteoclasts are cells that are going to break down bone. Osteoclasts do not come from osteoprogenitor cells. They come from white blood cells. There are a large number of these monocytes, which is a type of white blood cell, that fuse together, and they're going to use lysosomes. And they're going to break down the bone. Which is that bone resorption. So breaking down bone. It's a normal process. At any point, right now even, some of your bones are being broken down to repair, to rebuild it. Your certain parts of your bones are being replaced every 10 years or so. So this is what helps to keep your bones strong, keep them healthy. They are going through this resorption. It's how bones grow and develop. We'll look at that here shortly. That's how we're maintaining our bones. And if you've ever broken a bone, those osteoclasts come in and get the area ready to go. So when osteocytes can come in and start rebuilding that bone that had been damaged. So here is both drawings and pictures or electron micrographs of these different cells. So we get these osteoblasts that started as osteoprogenitor cells. So these osteoprogenitor cells go to osteoblasts. Those osteoblasts, they build that bone and surround themselves and become osteocytes, sorry. And then from our white blood cells, we get osteoclasts that are going to come in and resorb or break down that bone. So we did look at compact bone and tissues. So let's kind of look at it again. Compact bone is the strongest bone tissue we've got. It's underneath that periosteum, and most of that diaphysis of long bones is that compact bone. It protects. It supports. It's also going to resist the strains that you put on your bones through different types of movement. We have those osteons. So this picture shows it very well. An osteon is this entire circular area. So one set of rings, tree rings as I call them, but one set of rings makes up an entire osteon. They are laid out in concentric bone lamellae, or those rings. We have those bone lacunae. Within those bone lacunae are those osteocytes. So let's look. So all of these cells here, these are those osteocytes. They're sitting in that lacunae, meaning they built all of the bone around them, completely surrounded themselves into that bone when they were osteoblasts, and then they became osteocytes. So they built up everything around them, and now they're housed and living in that area, monitoring and maintaining that bone. So here's that osteocyte, and these canaliculi, which are these little tunnels that these osteocytes, or when they were osteoblasts, built and maintained. This is how one osteocyte communicates with another osteocyte. This is how these osteocytes are getting their different nutrients. They're getting rid of wastes through these canaliculi. We also have perforating canals. So these perforating canals, we've got, trying to find it, this central canal that is found in the middle of every single osteon is going to have one of these central canals. We're also going to have these transverse canals that kind of go between the two osteons, or between osteons here. You can see some coming through here. This is how we get blood from one area to the next. So you can see how there is lots and lots of blood supply going to this bone tissue just to help maintain everything that is happening here. Spongy bone. I mentioned that spongy bone in that picture of the bone from before. Spongy bone is made up of trabeculae. We find it inside the bone, And it's usually protected, like covering, or it's found inside a covering of compact bone. It's named spongy bone because it looks like a sponge. A lot of times it's filled with yellow or red bone marrow. We're going to have blood vessels. They kind of weave throughout this spongy bone. This is a wonderful example right here showing these blood vessels kind of weave through all those little spongy areas to provide nutrients to all of these different cells that are helping to maintain that spongy bone. So each trabeculae, each little piece of bone tissue, going to have a lamellae, it's going to have osteocytes, and it's still going to have those canaliculi. The only thing that it does not have are those osteons, those concentric tree ring type circles. We've got spongy bone and short bones, flat bones, sesamoid bones, and irregular shaped bones. It's found in the epiphysis of long bones, so at the top of all of your long bones, and at the very bottom, that only shows me the top. So at the bottom of long bones, we also have spongy bone. Why are these trabeculae so important? It's supposed to help resist strains and helps with those transfers of different forces when you try to move without breaking that bone. Spongy bone may not look like it's very strong, but it's extremely strong, which is why it helps to protect those ends of those bones. Within the spongy bone, within your hips, your ribs, your sternum, your vertebrae, your skull, the proximal end of your humerus and femur, that is where we have red bone marrow, and that is where hematopoiesis, it's making of blood cells. So red blood cells, white blood cells, platelets, that's all done in red bone marrow. And that is the only place technically we have red bone marrow in the body. So I mentioned those perforating canals. We have periosteal arteries. So these periosteal arteries are arteries and veins that are found within this periosteum here, that covering of that bone. Those transverse canals that I mentioned in that picture, it helps get blood around that bone. We have nutrient arteries. A nutrient artery, here's a nutrient artery. Here's nutrient arteries. These are arteries that are going to go through little minute minuscule holes in the bone to help to provide those nutrients. They're doing exactly what it says. Nutrient artery provides nutrients. Whenever, we'll learn this now, you'll see it more. Whenever you see an artery and a vein, nerves follow. Nerves follow blood vessels. It's rare to see blood vessels without seeing a nerve following along. So we're always going to see arteries, veins, and nerves all traveling together. So when our bones form as an embryo, which is that first 8 weeks, and then the fetus, 9 weeks on, our bones are going to form 2 different ways. We're going to have that intramembranous ossification. That's that bone that forms within that mesenchyme. And then we have enchondral ossification. That is bone that forms from hyaline cartilage. So we build bones both ways. So let's look at this intramembranous ossification. So the first thing that's going to happen is we're going to create this ossification center where osteoblasts are going to come in, those bone building cells, and they're going to start secreting that bone matrix. The next step is calcification. So we're going to take calcium and phosphate, and these osteoblasts are going to help to deposit that in that matrix that they just built. And this is what calcifies or hardens that bone. As this bone gets formed, bone always starts as spongy bone. So we're going to build spongy bone. From this spongy bone, we're going to start to develop that periosteum. So that outer layer with that compact bone on each side and spongy bone in the middle. So those are these 4 steps. We do that. I just have it written out here, pictures on the next slide. Ossification center is going to start calcifying. We're going to start making that spongy bone. And then we're going to develop that periosteum, that outer layer to our bones. Chondral ossification. Here's all the words. Here's the pictures that say about the same thing, just written out versus pictures, whichever one works best for you. So in this case, we developed hyaline cartilage first. So that's that cartilage, that hyaline cartilage that comes from chondroblasts, because all cartilage comes from chondroblasts. Chondro means cartilage. Blast is building that cartilage. Once this cartilage has been, cartilage bone or outline model has been made, it's going to grow. Some of this extracellular matrix here is going to start to calcify. It's going to calcify to the point where we get this primary ossification center. This whole area is that primary ossification center. It starts in the diaphysis, so the middle of that long bone. And bone tissue has replaced that cartilage at this point. Now we've gotten to a point where we need more. We've got this nutrient artery coming in because we need nutrients to allow this bone to grow. We're going to build this medullary cavity, so that opening in the middle of this bone here. That's what's formed in all long bones. So we're going to break down any bone tissue that is in that area with osteoclasts to form that hollow cavity in the middle. Okay, now we've got the shaft or that diaphysis of our long bones. Now we need to fix the end of the bones. So we make secondary ossification centers at the top and technically at the bottom of each bone. So in the epiphysis, since we have an epiphysis at the top, we have an epiphysis at the bottom, it's going to happen at both places. And then we're going to need to form, we keep some of that cartilage at the ends of all of our bones, because all of our long bones, or most of all of our bones, have articular cartilage. All articular cartilage is that hyaline cartilage. We also form this epiphyseal plate. This epiphyseal plate, if I can spell, It's your growth plate. It's the same thing, but medically, it's called that epiphyseal plate. And this epiphyseal plate is going to remain here to allow these bones to grow longer until anywhere from 16 to 21 years old or so. This picture here is kind of cool. Just because it's a 12-week-old fetus, you can see the bones forming. You can see some of the calcification centers, some calcified areas. A lot of it is still cartilage. It's really cool because look at the hand over here. You don't see any bones in the wrist. Same with at the ankles. It's kind of cool because it's all cartilage, so it's not getting picked up by X-ray. This is an X-ray. So now that epiphyseal plate, that growth plate is split up into different sections. That growth plate is hyaline cartilage, but what is happening is we've got what's known as a zone of resting cartilage. This is closest to that epiphysis, and it has some chondrocytes. These cells are not making bone. They are doing exactly what the title says, resting. Nothing is being divided here. The next stage, that zone of proliferating cartilage. In other words, those chondrocytes, they're stacked like coins at this point. They are growing and dividing. We have the zone of hypertrophic cartilage. Those chondrocytes have gotten larger. Again, they are arranged in columns. Then we have our zone of calcification. At this point, our chondrocytes are dead. They're coming in and osteoblasts are coming in and laying down that bone matrix. Osteoclasts are getting rid of that cartilage. So here's on an X-ray, those of you who want to go into radiology or nursing or any area where you may have to maybe looking at X-rays, in children, they all have growth plates and cartilage, since it does not have calcium in it, is not going to pick up anything on an X-ray. So it's going to look clear, which is why it kind of looks like there's this big gap here, but it's all cartilage that's in that area. Same down here. This is just how X-rays look in anyone who still has a growth plate or that epiphyseal plate. Same exact thing. It's just where bones are growing. So let's look at what is happening. We mentioned the different areas of a growth plate. Now this is histologically what it looks like. That zone of resting cartilage. So these cells aren't dividing. They're not working. They're not doing anything at this point. Zone of proliferating cartilage. We mentioned those chondrocytes kind of look like a stack of coins. They kind of do because they're dividing. They're working on growing that bone out. The zone of hypertrophic cartilage. You can see these osteocytes have gotten larger, or chondrocytes, sorry, have gotten larger. And then the zone of calcified cartilage. In this zone of calcified cartilage, osteoclasts have come in and broken down that cartilage, and osteocytes are coming in and laying down bone. So that is all happening in this, within a growth plate. This is everything that is happening here. So I mentioned 16 to 21. Usually average it's females are 18 is when that epiphyseal plate closes. Males is closer to 21. And instead of that epiphyseal plate, you'll see this epiphyseal line, which if you remember back to that first picture that we looked at, you kind of see this line across. That's where that growth plate has closed. See if I can go up and find it real quick. Here. This epiphyseal line. This specific line here, this used to be a growth plate that has now calcified over. That bone is done growing. It will not grow anymore at this point. We use epiphyseal plates to determine bone age. This is how we can determine on skeletons that have been found approximate age of that person. We can predict the height of adults using these epiphyseal plates. As I just mentioned, the age of death of any skeleton that may have been found. It's some cool science that can be done with this stuff. So not only do our bones grow longer, they grow thicker. So we have osteoprogenitor cells that are on the surface of our bones that will make osteoblasts that are going to help grow the bone out in thickness. We're going to have different ridges that come together. They're going to fuse. They're going to grow tunnels. We're going to form lamellae, those circles. We're going to form new osteons as we increase that thickness. So here's an example. We get these periosteal ridges that are coming in right here. They're folding in on each other. So they're starting new lamellae that are going to form new osteon as that bone grows thicker. So it's a natural process that happens when you go from an infant all the way to an adult. It's a natural process that happens. That bone grows thicker out, but the inside also gets taken up. So then we're left with this large medullary cavity in the middle. Well, our bones maintain a pretty similar width from the medullary cavity to the outside. This width from young adult to an adult stays pretty similar because it's carrying a similar weight. This is something that's going to happen throughout the entire development. And this continues to remodel throughout adulthood even. Because our bones are remodeling. They're constantly replacing old bone with new bone. So those osteoclasts have to come in and reabsorb or remove collagen, calcium phosphate, and then those osteoblasts are going to come in and lay down new bone. So there's about 5% of your bone mass being remodeled at this moment. Here's some just interesting cool facts. The distal end of the femur is replaced every 4 months. So the bone that makes up the top part of your knee, that's replaced every 4 months. That's kind of cool. But your diaphysis will never get replaced of that same bone. We remodel, maybe exercise. Exercise causes your bones to get thicker and stronger. Sedentary lifestyle causes your bones to get thinner. Changes in diet. Well, if you're not taking in enough calcium and phosphate, your body needs to get it somewhere, so they're going to take it from your bones. Or you're taking in too much calcium and phosphate, it's going to get stored in your bones. So those osteoclasts, they come in and they're going to break up bone. They attach so tightly to that bone surface that they kind of produce this leak-proof seal. They use these lysosomal enzymes to break up that bone, that collagen, the calcium phosphate crystals. They dissolve. Osteoclasts are going to work together at the same time, several of them. Then these osteoblasts will come in and rebuild that bone. So here's something kind of interesting. Anybody who has ever worn or had or does wear braces. Here's how braces work. So they put those braces on and they kind of tighten to try to straighten out your teeth. What they're doing is they are putting a strain on the bone. That bone specifically that forms the socket where your tooth sits in. So because of that strain on that socket, those osteoclasts are going to just break down some of that bone. Osteoblasts are going to rebuild that bone to start aligning your teeth. Then they tighten them again. They do the same thing. Those osteoclasts are going to break down. Those osteoblasts are going to rebuild to help completely straighten your bone and or straighten your teeth. And they're going to continue to do this until your teeth are straight. Something else, Paget's disease. Paget's disease it's too much. Those osteoclasts are working too hard. So they're breaking down more bone than new bone can be laid down. And because of this, those osteoblasts are working really fast to try to compensate. So that bone becomes much weaker. It's not as strong as bone should be. This happens in the pelvis, the skull, the arms, the legs, the lower vertebrae. So in somebody who has Paget's disease, their bones become enlarged, hard, but they're very brittle because those osteoblasts are trying to catch up to those osteoclasts, breaking down bone. They can't build the bone as fast as those osteoclasts are breaking them down. So somebody with Paget's disease, see it on this left side, on that side extremely well. We're looking face on. So their left side is your right side when you're looking at it. You see all of these holes throughout this bone. All of these holes is because osteoclasts have broken down that bone so fast that those osteoblasts building bone can't keep up. So this is called like a moth-eaten pattern. This is what you'd see on an x-ray of somebody who has Paget's disease. So I mentioned a few things that are going to affect your bone growth, like exercise versus a sedentary lifestyle. Well, minerals. We need a lot of calcium and phosphorus for your bones to grow and be remodeled. We need vitamins. Vitamin A stimulates that osteoblast activity. Vitamin C is used for collagen. Vitamin D helps to build bones. Here's a little tip. Vitamin D is used to absorb calcium from your digestive system. Without vitamin D, we cannot absorb calcium. Can't absorb calcium, we can't build bones. Vitamin K and B12 help make different bone proteins. Then we have hormones. Hormones are always going to play effect on everything in your body. So insulin-like growth factors, those help bones grow. Growth hormone, thyroid hormones, insulin. These technically 5 hormones because these thyroid hormones are each their own. There's a T3 thyroid hormone and a T4. But so these 5 different hormones help your bones grow. They help maintain your bone. So they're all very important. Something else, puberty, estrogens and testosterone, those sex hormones. They are what cause growth spurts in teen years. They also cause estrogens in females will widen the pelvis. They shut down growth plates, and then they help to remodel bones. Moderate weight building or weight bearing exercises, putting strain on your bones helps to maintain your bone density. I've mentioned in classes before, some of these different systems are speaking to why you should exercise. This is one of them, especially females. When these estrogens stop at menopause, bone density goes down drastically in females who do not exercise, who maintain a very sedentary lifestyle. Exercising now, building and maintaining bone density can prevent losing that bone density later on in life, maintaining an exercise schedule and all. That is, not doing it now and then stopping later, maintaining. So what happens if we get too much growth hormone? Too much growth hormone causes giantism. These people can be anywhere from 7 to 9 feet tall, much taller than an average human being. What happens if there's not enough growth hormone? That can cause dwarfism. So these people are usually under 4'10". And then we have a condition that is caused achondroplasia. This is where that conversion of hyaline cartilage to bone is abnormal. Long bones in the arms or legs stop growing. In achondroplasia, that clavicle, that collarbone, may never actually calcify. It may stay completely cartilage. These people have really short arm, could be a really short arm or leg, or both. It's very interesting, some of these conditions. So let's look at fractures. A fracture is considered any break in a bone. There's different names for different fractures. So they are named on the severity, the shape, or the position of the fracture line. We're going to look at some different types of fractures today. So a stress fracture is where you get this little microscopic fissure. So like a microscopic line in a bone. Your textbook says it forms without any evidence of injury, but it is usually from repeated strenuous activities, such as running, jumping, or aerobic dancing. Don't ask, your book wrote it. But stress fractures, you'll see these in like distance runners, like endurance runners may come in with some sort of stress fractures. They're hard to see on x-ray when they first happen. It takes till the bone starts remodeling for you to really start to see those. Bone scans are a better way to see a stress fracture. But they can also be from osteoporosis. This is where you get a significant loss in bone mass because of its decrease in estrogens in females. It's most common in females, and this is why, is because that significant decrease in estrogens post menopause. The most common stress fracture place is actually in the tibia, that lower bone leg, that hard bone that makes up your shin. That's your tibia. So when a bone breaks, there's going to be that reactive phase because that we need inflammation. Inflammation is going to bring in immune cells to help kind of clean up the area. So since we looked at how many blood vessels are actually found in bone, blood vessels are going to break. Any blood vessel that has crossed that fracture line usually breaks. And this is what's going to cause this hematoma to form. This is where most of those cells in that area are going to die. We're going to see that inflammation and swelling, that redness, that poofiness to that area. If you've ever broken a bone, you know what I mean. Phagocytes, those immune cells come in and kind of ingest anything that shouldn't be in that area. And those osteoclasts are going to remove dead tissue, break that fracture of the bone, depending on what happened to it. They're going to come in and kind of get rid of it so we can lay down new bone. We get a reparative phase. We start with cartilage. So we get a cartilage callus. I want pictures. So here's this reactive phase. We've got this nice break in this bone here. So any blood vessel that was in that area broke. This hematoma forms. That hematoma is going to turn into this callus, that cartilaginous callus. So cartilage comes in and builds first. Then we get this bony callus. We still have this enlarged area around this bone. Do you see, spongy bone gets laid down first. And then it'll come in and remodel this bone. So we get this compact bone on the outside. And then we form this medullary cavity in the shaft of this bone on the inside. That is what all of these words are saying here in these pictures. These are the different stages to bone formation. We're reforming bone after we break something. So for those of you who've broken a bone, how they treat that bone is going to depend on your age. The younger you are, the better your body is at fixing it. Also the type of fracture. How many pieces did you break that bone into? And what bone is involved? Sometimes, just depending on what bone is involved, it requires more treatment than just putting a cast or a splint on. I broke my thumb in 5th grade, I think. They put a splint on it because it didn't need anything else it didn't need any cast or anything. They were like, a splint will do. So If you've got a lot of bone fragments, they want to realign them. Put everything back into that straight line so that bone can reform the correct way. They immobilize it, prevent you from moving it so that those bones can heal in a straight line the way they're supposed to. And then they work on restoring function. So they reduce a reduction of that fracture, setting it so its bones are lined up the way they should be again. There's two ways they can do that. They can do a closed reduction, where they could do a manual manipulation with the skin intact and move those bones back into place. So our body, our osteoblasts and osteoclasts can work to put that bone back together again. We also have an open reduction. This is where they can come in and put screws, pins, plates, rods, wires, and they do this internal fixation to line back up the bones. Like my mother, who fell off, like stepped at the edge of the sidewalk just the right way and broke her ankle into several pieces. She shattered it. She's got a plate and I think 12 screws in her ankle still. So it just depends on what kind of fracture it is, how it was done, for how to treat it. So there's different ways that they can immobilize it. They could use a cast, a sling, a splint, elastic bandages, an external fixation device, or any combination of these, just to try to keep the bones aligned so that so our body can heal it. Bone is very good at healing itself. It just needs to have things lined up right so it does heal correctly. Because if it's not lined up correctly, your bone's going to do its best to remodel itself, all these cells, but it's not going to be straight. So an open fracture is when that bone protrudes through the skin. That bone is going to break through that skin. Comminuted. The bone is broken into several pieces. There's lots of small pieces here. Green stick. Past question. If you've ever, when you were a kid, if you ever played with a stick that was still green inside and you notice how you could kind of bend that stick and it'd kind of peel before it'd actually break, it'd take a lot to break those because they'd kind of just peel instead. That's what a green stick fracture is, and it's most common in children. It's named green stick because of those green twigs. Only break on one side. It's considered a partial fracture, where just one side of that bone is broken and the other side kind of just bends. Again, most commonly found in children. An impacted fracture. That is where one part of the bone goes down inside of the other part of the bone below it. It's forcibly driven into the bone below it. Those are the most commonly ones you're going to see. These ones, a Pat's fracture, these are more specific, but it's going to involve that distal fibula. This is a break in what is known as that lateral malleolus. That fibula has that lateral malleolus to it. A Cole's fracture is that distal radius. Here's another one you'll see. So knowing it is a compression fracture. This is most common in people with osteoporosis. These are more pathologic fractures, people with severe osteoporosis, literally all they'd have to do is go from sitting to standing. That change in body weight is enough to cause one of these vertebrae to kind of collapse down on itself. That's a compression fracture. So let's look at calcium homeostasis, because that's our bone's job, is to maintain it. And we store almost all of our calcium in our bones. But we use calcium for other things. We use it for nerve and muscle communication. When we get to the muscle chapter next, we will look at this in more detail. Blood clotting. It is also a cofactor for different enzymes. So as a cofactor with an enzyme, it just means that you need calcium and then you need whatever to bind to it to cause that reaction to happen. So whatever we're trying to break down or build with those enzymes, plus calcium, will cause that reaction to happen. Without that calcium, it's not going to happen. We have to maintain a very strict blood calcium level, usually between 9 to 11 milligrams per 100 milliliters. A very strict level. It's fatal, or could be fatal if it falls outside that 9 to 11 milligrams. So we store that calcium in our bone, and it's used as a buffer. Your calcium levels get too high in your blood, it's stored in your bones. Calcium gets too low, we take it from our bones. And one way to do that is through hormones. Parathyroid hormone is monitoring. Parathyroid gland, one of our endocrine glands, is helping to monitor your blood calcium levels. So if we have an increase or a decrease in blood calcium, your blood calcium level has gotten too low, what it's going to do is it's going to help to take in calcium, break down calcium from your bone. I'm saying it backwards. I am sorry. There's one hormone that does one way and one hormone that does the other way. Parathyroid hormone, it does increase your blood calcium level. So what it's doing, so your calcium level falls below that 9 milligrams per 100 milliliter. What it's going to do is it's going to go to different places. It's going to go to the bones to reabsorb some of your bones to release that calcium into your blood. It's going to cause your kidneys to reabsorb any calcium that it may have gotten rid of. It's going to go to your intestines. It's going to use that calcitriol, which is vitamin D, and absorb calcium from your intestines, from any food that you have eaten. So parathyroid hormone works to increase that blood calcium level. So your blood calcium got too low. This is the main hormone that regulates. Last question. The other hormone is calcitonin. This comes from the thyroid gland. And it's going to inhibit those osteoclasts. So we don't need to break down bone. Instead, we need to store that calcium in our bones. Why? It's lowering blood calcium levels. So we put it into the bones. But it also goes to the kidneys to secrete out, to get rid of calcium. But we're only dealing with bones. You'll deal with kidneys and the renal urinary system and anatomy too. So we're just looking at this aspect of it. Your blood calcium gets too high. We increase our blood calcium. It's not the one I wanted. Parathyroid is increasing. Calcitonin is lowering. They work opposite of each other. They're antagonistic. Just throwing the word out. You'll hear it again later. I mentioned exercise. So by putting strain on your bones is actually going to make your bones stronger. By putting that mechanical strain, your bones become stronger. High impact, going to influence your bones more than lower impact. So running, jumping actually stimulates your bones to be stronger than walking. And what causes that is those muscles that are pulling on that bone in those areas where they attach. Somebody who does a lot of weightlifting, so they're putting a lot of strain on their muscles those muscles are pulling on those bones. They have a lot larger prominences on their bones where those muscles attach than somebody who's on bed rest. Somebody who's on bed rest has lost a lot of bone density. So their muscles aren't pulling on their bones, which means those areas where bone muscles attached to bones have become very, very small, or maybe even insignificant if they've been on bed rest long enough. An interesting one, astronauts. They actually lose 1 to 2% of their bone mass per month that they're out in space just because of gravity. There's that microgravity. There's less gravity pushing down on them that causes so they're not using their bones and their muscles in the way that they would if they were under the normal gravity that we have here on Earth. Athletes, their bones are much thicker and stronger. Just by walking and just some moderate weightlifting can help retain your bones. But the higher physical demand you put on your bones, the stronger they will be. Adolescents and young adults actually should start weightlifting now, should start building their bone mass now, because it is inevitable that you're going to lose bone mass with aging, and this is a way to prevent it. So as we get older, or actually we start from birth, your bone mass is increasing. So you're building more bone than you are losing through adolescence. By the time you're a young adult, your bone mass and reabsorption is about the same. As those sex hormones start to go down, women and men after menopause, bone mass goes down significantly because bone reabsorption, that breaking down, I should say osteoclasts. We're breaking down more bone than we are building. And in old age, again, we are reabsorbing more bone than we are gaining. Women typically lose more bone mass and have a higher rate of osteoporosis because of menopause. So, women, when they get older, their bone mass is going to go down. Their bones also become a lot more brittle. This demineralization is the loss of calcium from the bone. It starts at the age of 30 in women. That's pretty young. It starts to speed up around 45. And you can lose up to 30% of the calcium in your bone by the age of 70. That is a lot. Once women start losing their bone mass, they lose about 8% of their bone mass every 10 years. Males, on the other hand, they don't start losing bone mass until after the age of 60. And they only lose about 3% of their bone mass every 10 years because the levels of testosterone in males does not drop like estrogens do in females. After menopause, females do not get estrogens from their ovaries anymore. They only get it from their adrenal glands in very small amounts, not enough to maintain bone mass. Unlike males, their testes can continue to produce testosterone to maintain their bone mass. Brittleness. It's because of that decrease in protein synthesis, that decrease in collagen production. This makes bones more susceptible to fracture as you lose collagen within your bones. This is where osteoporosis comes in. It's known as porous bones. It affects about 34 million people every year. Another 44 million have what is known as osteopenia, which is just low bone mass. But it puts them at risk of osteoporosis if that bone mass loss continues, because we are breaking down more bone than we are laying down. It's because of that depletion of calcium. And we lose calcium through urine, feces, sweat. As that bone mass goes down, fractures are a lot more common, and they can be just spontaneously from everyday stressors. Like I mentioned with those compression fractures in the spine, just going from sitting to standing is enough of a change. It's an everyday stressor on the back that can cause that vertebrae to just collapse on each other. Osteoporosis will affect the entire skeleton. It doesn't affect just certain joints, like certain diseases will, or certain bones. Osteoporosis affects everything. So we get these pores in the bones. That's why it's known as porous bone. The vertebrae shrink. You're going to lose height and become hunched back, especially as vertebrae collapse. And it causes bone pain. Middle-aged and elderly women are 80% of the population with osteoporosis. Why? Men's bone tends to have more mass to it than women. And I mentioned that production of estrogens in women declines after menopause because they're no longer getting it from the ovaries. So what puts people at risk of osteoporosis? If someone in your family has osteoporosis, it increases your chances. If you have a European or Asian ancestry, if you're very thin or small body build. An inactive lifestyle, like to sit around. Cigarette smoking. Cigarette smoking affects everything in the body. Not getting enough calcium or vitamin D. Drinking more than 2 alcoholic drinks in a day. And there's certain medications, like certain steroids, like prednisone, if you've ever heard of that, that can start to break down your bones with long-term usage. So osteoporosis, doctors tend to take a family history because they want to know if somebody in your family has already had it, and they'll do a bone mineral density test, like a bone scan, because that bone scan can detect the rate of bone loss. How fast are you losing bone? And it can help to diagnose that osteoporosis. So there's a lot of things that can affect bone, your bone growth, different minerals, different vitamins, different hormones, that exercise, and then, of course, aging. So for somebody who has osteoporosis, they tend to get a diet that is very high in calcium. Again, they're trying to reduce the chances of fractures. They also need high levels of vitamin D because we can't absorb calcium from our digestive system without vitamin D. They're also prescribed regular weight bearing and resistance exercises. So walking, weightlifting. There's also some different medications out there. There's anti-resorptive drugs. They're trying to slow down those osteoclasts from breaking down that bone. We also have different bone building drugs that are going to stimulate those osteoblasts to build more bone. There's also estrogen replacement therapy, but it does bring an increased risk of stroke, blood clots, heart disease, breast cancer, and dementia. There's some newer ones out on the market, but they're still working on a lot of these side effects. So it's very hit or miss. And this is kind of a nice example. It shows a normal bone, spongy bone on one side, on the left side. On that right side, you can see that osteoporotic bone. You can see all those holes, those little pores found throughout that bone. That's why it is known as porous bone, because all those pores are where those osteoclasts are breaking, taking up bone. There's some other diseases out there. Osteomalacia and rickets. Rickets affects children. Osteomalacia affects adults. It's the same thing where they have an inadequate calcification of their bone, and it's a vitamin D deficiency that is causing it. Meaning we replace that vitamin D, it can help fix this problem. So when a child, their bones become soft and more rubbery, they have a bow-legged appearance, like legs that kind of bow out. They could have other deformities, depending on how long they've been going on with rickets with this vitamin D deficiency. In an adult, new bone is forming, but it doesn't calcify. It gets very painful and bone, like it's very tender to touch. So they make sure these people get enough vitamin D. And they need to make sure they're getting enough sunlight. Exposure to that sunlight allows your skin to make that vitamin D. That's that's a vitamin that our body can make if exposed to enough sunlight. Again, this is how your integumentary system, your skin, and your bones work together. We need that vitamin D produced from our skin to go to our digestive tract to absorb enough calcium. It can help keep your bones strong, along with exercise. and weight training. And that is everything for bone tissue. Thank you very much for listening and have a wonderful day.